Oh, okay. Thank you, Professor Hariri, actually, for this introduction. And honestly, it's a great pleasure for me, to be among you here. This is my first time to stand off an audience at the city. I just joined about something like 5 days ago to the city. I'm just learning everything about it. It's a completely different ecosystem when we're talking about scale and the impact expected from such an institution. My name is Wael Ar. I used to be the president of Cairo University, which is a university dedicated for research, innovation, and entrepreneurship. A week ago, I moved the acting executive president for the World City. And by definition, the World City was founded to be one of the national locomotives in research innovation, focusing on particular domains that are really affecting humanities, and particularly, the most of interest, the national and regional domains. Very recent, the area of AI has penetrated every aspect, actually at home. You could see it everywhere, and it's becoming so scary that really what's going to happen and how we're going to work with that. Yet, we believe that with the proper education, with the proper awareness, with the proper competences, we can really turn this giant gene in our favor, for the next few years until it takes over the world, as everyone's saying, but yet still we believe that there is going to be a huge room for this. Being said, as I'm not an expert in this particular, very specific domain, I'm a mechanical engineer, by the way, but we have a unique mission and vision here at the World City. This mission and vision is really focusing on how we're going to deploy whatever expertise we have, either on the knowledge in the research centers, with competences and skills in the innovation and entrepreneurship domain, to transform whatever we have into an economic value and with an economic impact. Well, research by itself is important. Having an impact is the thing that counts when it comes to how valuable we are doing our work, how passionate we are doing our work. This impact is measured in many ways. So we believe the World City will come back to its leadership position. We hope that it comes back to its leadership position. We hope that it's really at the forefront, not only on the research measured in publications, but also in patents, intellectual property, and even startups and spin-offs emerging out of the research institutes that we have to have a real impact on the society, nationally and regionally. And this is the mission, and this is my objective for being here. And we are going to work all together with our colleagues from the research institutes and our colleagues from the business sector in order to really exploit whatever we have, the assets and the value and the colleagues and the infrastructure to its maximum capacity towards a very, very fast track of growth in this domain. There is a huge potential here at the World City. And I have been here just only for 5 days. 5 days, but I have learned enough to know the potential that the World City is having and the impact that it should have. In addition, I believe that this is a national project that has the backup of the government, has the backup of everyone who is really keen to make it to the next level of transformation of the research to impact measured by an economic value. This is pretty much the objective and the line of action of the World City, irrespective of the domain. It can be in the genome, it can be in the agriculture, smart agriculture or digital agriculture, it can be in pharmaceutical, it can be in engineering, it can be in electronics, but it always has to lead to an impact which is exactly what we are looking for. I don't know if this is relevant to this elite workshop, because again, I'm not an expert. I'm trying to say what we plan to do at large. In the next couple of months, in a few months, I just want to share with you that we are going to meet and to work with every research group at the Whale City in order to identify what it needs in order to achieve this goal. This is a goal for the city itself that is transferable into objectives for each research institute and each research center. And this is our plan, and we are working very hard, and I'm really counting on the expertise and the qualities that I have learned by the different distinguished faculty members and the teaching assistants and the research assistants and everyone here at the Whale City who is really keen to do something different. Again, thank you very much for inviting me. Thank you very much for being here, everyone. And I could see some good familiar faces from my old university here at this workshop. And I'm proud to be among you here and looking forward for a successful, impactful workshop where we deploy AI in the genome and genetics. And by the way, there are two Muhammad al-Hadidis. I mean, I don't know if you know this or not. This is one star here at the Whale City, and we used to have another one star at Nalavet, but he left, I think, to Birmingham University. But this one looks much smarter. He's very handsome. The other one looks much older. Anyway, thank you very much, and really looking forward to see the impact of this workshop. Thank you, Dr. Muhammad. Unfortunately, I really have to leave because this is my first few days, and there is a pile of paper to sign and to get things running. So thank you again.
It's really great to hear you. By way of introduction, my name is Marina Albata, and I am the leading India and Asia coordinator for the Global Health Network. It's an affiliated body for the University of Oxford. The Global Health Network is a global decentralized franchise network that is driving equity in where research happens. The Global Health Network works by transferring the know-how and exchanging knowledge between organizations, disease area, regions, and by guiding faster and improved research processes. This platform is working online, and it aims to improve and encourage clinical research in places where research is lacking, such as disease of poverty and outbreaks. Exchanging knowledge between organizations, disease area, and regions. Professor Trudy Lang is a faster and improved research processes. This platform is working online. Professor Trudy is the director of the Global Health Network and professor at the University of Oxford, such as disease of poverty.
Good morning. Thank you. Just checking you're here. Very wonderful to be here. Thank you so much for inviting us. We've got a really exciting morning ahead, I hope. And you're going to hear from lots of our colleagues who are just really exploring how we use AI in health and health research. I hope we're going to be challenging and really look at some of the potential. Everybody maybe is nervous about AI or excited. Is it going to take jobs? Is it going to steal all our information? Or is it going to transform the way we access healthcare and treatment? So we really have an exciting opportunity today. And I just challenge you all to ask questions and listen and really inquire. We're coming here having had similar workshops literally across the globe. We were talking about this in Japan before Christmas. There's workshops globally with this amazing network that we have. And so it's so exciting to be here in Cairo with you all. And I know we've got colleagues online as well, so welcome to you all as well. And I hope that we're going to set the scene with introducing some of these projects. But the word workshop is deliberate. We don't want to stand and talk to you for today. We want you to share with us and engage, and we want to listen as well. So thank you so much. From the Global Health Network, I'm going to tell you more about that later. We're going to hear about the other projects. And thank you to our hosts for this amazing university. And I'm just looking forward to talking with as many of you as possible during the breaks and to hear more about your work as well. So thank you for hosting us, and I'm looking forward to the workshop.
Thank you, Professor Julie, for setting the tone for today's discussions and for leadership in global research equity. I am Zaina Khattab, a recent biomedical science graduate and a research assistant in the Center for Genomics affiliated to Zuweil City University. I'm honored to introduce Ms. Shitali Sina. She couldn't join us in person, but she has shared her remarks with us in a short video. Shitali Sina is a senior program specialist in the Global Health Division at Canada's IDRC. She has over 20 years of experience with research for development in Africa, Asia, Latin America, and other regions around the world. Could you please play the video?
My name is Jacob Sinta, and I work as a senior program specialist in the Global Health Division at Canada's International Development Research Centre, IDRC. Thank you for inviting me to share a few words on behalf of IDRC and the AI for Global Health, or AI for GH program that we fund. For those who are not familiar with IDRC, we are part of Canada's foreign affairs and development efforts. Our mandate is to fund and promote research and innovation within and alongside developing regions. In addition of funding and supporting innovative and high-quality research, IDRC also places strong emphasis on sharing and positioning evidence to influence positive change and in mobilizing alliances across sectors and disciplines to ensure we can go further together rather than going alone. Now, with that background, I think you can imagine how excited I am about the agenda of today's meeting. Unfortunately, I can't be there with you in person, but I'm really glad to be able to share a few opening remarks. The mix of government officials, innovators, academics, WHO colleagues, civil society actors, and private sector entities at this meeting is so heartening to see because having and the use of responsible AI within it is something we are all responsible for and for which we need to work together on. The truth is, although we are living in an age where we can look back and celebrate many achievements in health and well-being, there have been significant ground lost due to a combination of stresses on health systems and society at large. From conflict to climate change, these challenges have converged to deepen inequality and lead to competition over finite and often fewer resources. Increased use of AI is not a cure-all. In fact, it may be responsible for creating divides of all kinds with great ease, limited accountability, and at a breakneck pace. IDRC has been supporting research on responsible AI for quite some time. Responsible AI, the way IDRC defines it, is AI that is ethical, inclusive, rights-respecting, and sustainable. Among our investments in AI and development is a significant portfolio of work that looks at global health, and much of this is housed within our AI global health program. There are two entry points that we look at, the first being sexual, reproductive, and maternal health and rights, And the second, epidemic and pandemic prevention, preparedness, and response, especially in light of climate-sensitive infectious diseases. Across all the different regional and global nodes leading this work within AI-PGH, some of whom will present their experiences at this meeting, there are cross-cutting emphases as well within AI-PGH on policy, governance, and knowledge sharing. The lens adopted for AI-PGH is that of implementation research. And in the AI and global health context, implementation research can help bridge the gap between what is expected to happen when promising AI solutions are designed and what actually happens when they are implemented in real-world settings. These implementation outcomes are looked alongside traditional health outcomes. In a recent paper released by IDRC in March of this year, an emerging research landscape is presented. It is based on interviews with key informants, which include innovators and academics, WHO colleagues, and decision makers working on these issues, and most of them based in the Global South. The emerging research agenda has 3 areas that it puts forward and 5 cross-cutting prerequisites. But what I'm most excited about in this paper is the 12 case studies that it puts forward, which feature initiatives across AI-PGH, several of them from the Middle East, North Africa, and Asia. Each case study is grounded in their own local context, a clear implementation research question, lists the progress to date, and is clear about the AI model that is used, which is not often made transparent when people talk about successful AI initiatives. And also each case study discusses why the particular AI-enabled solution qualifies as being called responsible. In conclusion, artificial intelligence holds immense promise to advance health equity, strengthen systems, and improve the lives of communities often left behind by traditional models of care. However, what we also see is that the design and implementation of these innovations are not merely technical in scope or in repercussions. They are political, they are social, they are cultural, they are economic, and underneath it all, they are deeply human. Deeply human in both its promise and its peril. At IDRC, we believe that the best solutions to health and other challenges need to be rooted in the countries and communities where the impacts are felt the most. This involves examining and integrating national policy and regulatory considerations, community leadership, and addressing prevalent social and gender norms. The AI-PGH initiative supported by IDRC and the UK's Foreign Commonwealth Development Office was founded on the belief that the Global South must not only benefit from AI, it must shape its future. Through our work with researchers and policymakers across more than 50 countries, we have seen that responsible AI must be built with public values through inclusive partnerships and with deep respect for regional context and expertise. Thank you for your time, and I wish you a wonderful event ahead.
Thank you, Ms. Chitali and IDRC for continued leadership in responsible innovation in health. I would like to welcome Dr. Shadi Saleh. Dr. Shadi Saleh is the founder director of the Global Health Institution at the American University of Beirut. In addition, he's a professor of health systems and financing at the American University of Beirut. Dr. Shadi, I now welcome your reflection.
صباح الخير ازيكم so first of all let me start off with start off with a few thank you notes for the people who were involved in this. I want to start off by thanking IDRC for the support, not only for us across the years, but also for the Global Health Network. I want to thank the Global Health Network who did a great job but postponed this event for many months. And I think it's all because of Trudy, so thank you again. It's good, the weather is better now. Dr. Khalidi for all of the efforts. And a special thank you for Zuwail City. Yani Zuwail City is the host of this event. This is the first time we've been here. It's impressive, the vision of Dr. Zuwail, who I'm sure you know who Dr. Zuwail is. And I've got to know how much Dr. Hadidi has supported this event in many ways. So thank you, Dr. Hadidi, for all of the So two things that I want to talk about when it comes to AI that are practical and we have to think about. The first is the issue of responsible AI. And the second is the issue of we as a region, how should we navigate the AI discussion. So the first topic, which is the responsible AI, one thing that we have to realize is, unlike other digital tools that we use on an everyday basis, like Google, Instagram, Facebook, and so on and so forth, AI has the potential to get into our most personal information that we can use, not only financial, but also health, but also security issues. So it's extremely important that as we roll out artificial intelligence in our region, we do that keeping in mind that we have to do it in a very responsible manner. Having in the countries of the region safety measures that imposes on the adopters and users of AI to have that security issue. Advanced countries such as those in North America and in Europe have strong governance structures, okay? Dual qawi, that are able, the system is able to safeguard some of that and not to 100%, right? So imagine what will happen to us in this region where our states are weak technologically when it comes to that. So I hope the discussion today would address some of that as well, the responsible AI thing. The second component that I want to talk about is the whole adoption of AI. Most of the studies coming out in the past 2 to 3 years are saying that low and middle income countries, LMICs, including countries in our region, will lag when it comes to the adoption of AI. That means that high-income countries, talk about North America, Europe, their adoption of AI will be much quicker, much faster, and they will set the stage of what AI is, how it's used, so on and so forth, including that of health. We, based on the most recent studies, LMICs in general, including in this region, we will be lagging by 5 to 10 years. So imagine how much of a technological disadvantage we will have if we catch up in 5 to 10 years. Imagine if everybody started using Google, just to give you an example. Google in 2025 or 2020, and we have started using Google in 2030. Can you imagine that sort of technological gap that we will be facing? So it's very important, and we are counting on you, on us, on our colleagues at WHO to support, and other organizations to support in our quicker adoption of AI, and talents from the region, okay, you people, we from the region, to start engaging more and more in AI, technological advancement, coming up with ideas, applications in health, and so on and so forth. So responsible AI and working together on advancing our region's agenda when it comes to AI, and not wait to sort of import it. And everything we import is one size fits all. So whatever is developed in Europe, in the UK, in the US, and we adopted, it's something that has mostly been developed for their use, not for our use, not for our context. So that's why I will end with this. That is why we at the Global Health Institute at the American University of Beirut, we were keen 2 to 3 years ago to start a program within our portfolio that is dedicated to digital health. In it, we have a big component on artificial intelligence. We have been designated by IDRC as the regional hub for AI in global health. So that program is now a regional hub. So I would invite all of you to engage with us. Definitely now knowing more about Zuhail, we would be also happy to engage more with Zuhail, but please reach out to us. Let's work together and move the agenda of responsible AI and AI adoption together. So thank you very much. إن شاء الله ما كنت طولت عليكم. يعطيكم العافية. شكرا.
We have a banana for 4. Is it okay? Thank you, Dr. Shadi, for your inspiring remarks and for your commitment in the regional health equity. Now we want to move to our second part of today's workshop, where we will mark a 3 presentation from esteemed professors we have. This segment will explore the broader ecosystem of AI in health, from a global research to health systems and policy making. We will begin with Professor Trudy Lang with a presentation titled Global Health Research, Bridging in the Gaps. She will explore more about the global health network work around the world, especially focusing in the low and middle income countries, and then she will touch base on the AI work that we are doing within the TGHM. Professor Lang.
Neat, thank you very much. So this is why I kept my opening remarks short. I didn't want to bore you with my with my sessions. So thank you very much. I really want to try and just set the scene for us today, and it's lovely following on from the opening remarks, because this is all about equity and about making sure that the countries that are less resourced are not left behind. And so I'm going to talk you through what we're doing with the Global Health Network and how that has evolved. And so I've got 2 sort of purposes today, is really to invite you all to become part of the Global Health Network family. It really is how we see it. And also this opportunity to collaborate and work together, which is what this is all about. You know, I think AI and health research in general is the most exciting and transformative opportunity that we have to really change health outcomes across the globe, and harnessing not just AI, but data science in the widest sense. I'm going to be very excited to listen to one of our new collaborators in a second. And I'm only going to talk for about 15 and 20 minutes, but that's when the workshop proper begins, because I would like to have this as a discussion. So I'm going to try and keep my remarks quite brief, and then I'm really keen for you to ask questions, and then let's discuss some points. Are the slides ready? To click forward. Can we have the slides up, maybe? Would be good. Perfect.
Just the clicks. No, the other click.
Ah, there we go. Perfect. So, it's really what I'm absolutely delighted by is I use my pyramid analogy everywhere, and here I am in Cairo. So I can finally use the pyramid analogy really well here. You know, we all know this, don't we? The age-old facts that 90% of the health research that happens in the world benefits just 10% of the population. And that's most of the investment that happens still happens from the global north. Research is led from the global north. And one of the big pieces we need to shift, and I talk about inverting the pyramid, is making sure that even when we have research happening in the global south or in less resource areas, that the beneficiaries of that evidence and those leading and taking part are really benefiting from that. From the whole process, setting the question, running research studies, generating and analysing the data, which I'll come back to later, and then which patients are benefiting from the data? Who is having the most impact from the studies that are happening? And for too long, we have research focusing in the top of the apex of this pyramid. These huge funded grants or the big pharmaceutical projects, they happen within very small communities of the world, run by a very privileged few and benefiting a privileged few. So if we think about the base of the pyramid, and I am so amused by using my pyramid analogy in Cairo, I love it. We need to go and get a photograph of the pyramid so I can put this into my slides. I literally use this all over the world. But we really need to think about who should we be empowering to be researchers. Not the sort of elderly professors and just stuck at the top of the pyramid. But we do a lot of work literally with the community itself, with frontline health workers, nurses, midwives, pharmacists. We really need to empower the entire research ecosystem to be champions and to gain evidence. And so throughout today, I want to think of it from that really basic point of inequity around how do we generate evidence everywhere in the health research ecosystem? And then, of course, how do we harness AI and data science? And then exploring the concepts of AI in this, obviously, if we need to think about fairness, ethics, and equity. So this is a slide that it pulls together some studies we've done over the years. And what is interesting is that every time we ask these questions, we get the exact same answer, which is depressing, but also shows that we can solve this. And this is something I've presented with the World Health Organization, studies we've done with them, with organizations like Wellcome, and with the Global Health Network community. So this is the combined data on around 14,000 people, where through different studies we've said to them, what is the barrier to you leading research wherever you're working in healthcare and health sciences? What stops you leading your own research studies? And the first barrier is know-how, the skills to do it, of course. But you know what, that's really easy to solve, and that's what we're going to be talking about more. The second barrier is the mandate. And this is really key, because this is wherever people work in whichever healthcare setting they're in. Maybe they're in a laboratory, maybe they're a community health worker, maybe they're a nurse or a clinician, wherever they are, their employer, their ward, their clinic, their lab, their pharmacy, they need to have the space and time and support to be gathering evidence and thinking about evidence-led practice. But that goes right up through the hierarchy, up to government level. That research should be not separate from healthcare delivery. The former head of science at WHO, Sumi Samanathan, said it's about measuring what's in front of you. And we talk about building research systems and health systems. And so that there's not a separation between understanding how you measure and how you improve health outcomes to actually delivering healthcare. And so this is what we're talking about today. But one of the biggest barriers is the permission, the mandate, the space and time. And so lots of the discussions that need to happen with our colleagues from WHO and EMRO over here, with the governments themselves and with healthcare leaders, is about valuing the return on investment that generating evidence can give. And of course, what we're talking about today is what is the role of AI in all of this, and can we use this as an accelerator and a force for good to try and shift this dial, and how do we do that within really good boundaries and buffer zones to make sure it's ethical and safe and fair. Look at this clicker. Perfect. So the Global Health Network began about nearly 15 years ago now in East Africa. And the reason we set it up was because there was really beginning to be a growth of health research capacity across Africa at that point. There were lots of new product development studies going on, HIV, TB, malaria, but these were still happening with people coming in from the global north, running these studies and the data going back to Harvard, Oxford, the big pharma companies. And the other thing that was really happening was there was no sharing between those big programs, which was ridiculous and completely inefficient. And then the outcome of that was not really training the local teams, addressing those first two barriers on that chart. So whilst there were really good examples of really high quality research beginning to happen and the infrastructures being built, there wasn't really the leadership and ownership locally and building data science centres, research laboratories, research nurses, research management, even things like running budgets and putting grant applications in. So what we recognised was that we needed to have this facility where people who work on research at whatever level can talk to each other, research nurses, data scientists, laboratory staff, and say, okay, well, I'm working on HIV and I've got this problem with my lab assay and I've solved it like this. Or I'm a research nurse, nobody's listening to me, the doctors ignore me, what can I do? And so trying to just create that space to have a dialogue and share and exchange is really transformative. I mean, we've seen that in so many things in the world, haven't we? This is called a community of practice, but it wasn't really happening for health research because it all happens in the top of the pyramid and everybody wants to hold on to their own information and their own knowledge. And that's one of the challenges that I hope AI can help overcome. There's, in health research, everybody's brought up in academia to fight for publications, fight for funding, protect their own corner as if it's, it's like their own island. We have to, again, flip the pyramid. I'm sorry for the analogy, but it's just great. We really have to change that upside down and disrupt those old hierarchies. And that needs this sort of open sharing of how to do research, how to build careers, how to build a whole team. And I'm really excited about the possibilities of AI in that application, and I'm going to talk a little bit later about that. So the Global Health Network was really set up to be this open, transformative space where people could literally support each other in doing their research and really make progress. It's just not a very good signal. I'm going to move on about 6 slides. Oh, there we are. So, where are we now, all these years later? So this is now a globally connected community of practice. We've got over 1 million members across the globe. And those members are literally everything from frontline community health workers, nurses, lab staff, clinicians, policymakers. It goes really through the whole ecosystem. And we have memorandums of understanding with over 60 different organisations around the globe. And I hope there's going to be several more after this couple of days in Cairo, because this is really about partnership. We were challenged at the World Health Organization a few weeks ago with the World Health Authority Directive on trials, that the only way really to build ecosystems everywhere is to work in collaborations and foster these ecosystems that can do this sort of knowledge exchange. And this is the whole point of the Global Health Network, to foster this open sharing and partnerships to transfer that know-how. And so we really are, I'm really struggling with this maths. I might get you to do next slide. Okay, I think it's just not what. So this is a really global community now, and over the last few years, many of us have been working to really try. It wasn't just me then. Oh, we can jump forward. So this began in Africa, and then it's extended across Asia and Latin America. We've really got quite significant programs. A nice example is in Latin America, when the Zika outbreak happened, which I'm sure you all remember, those babies being born with microcephaly, that many of those worst impact of that outbreak happened in the most resource-naive, research-naive centres with no research capacity at all. And then they had to all of a sudden gain all of that data on what was going on with Zika and how it was being transmitted. So the Global Health Network worked really hard to try and mobilise the activities between the research centres in Zika. And so we're trying to grow this across the global regions. And of course, the latest area we're really looking to try and connect and lead its own sub-community in this is the MENA region. And so Marina and Mohammed and colleagues in the room are really working to try and bring together research organisations across the Middle East and North Africa to have a focus in the MENA region. And this is a really exciting addition, and we're going to be talking about that a lot, Sophia, over the next couple of days. So how does it all work? Well, it's definitely this vast global platform, and you can all go online and have a look. Sign up and join, that would be wonderful, and have a look at the MENA area on the platform. And I'm going to explain more about how it works online to transfer knowledge. The other really important aspect is in person in the communities. And this is where it's really exciting. And so, the old-fashioned hierarchical, let's bring research into a hospital. I'm sure you've all heard of journal clubs. If any of you are clinicians, you'll have been working in hospitals maybe, and maybe there's a journal club that the doctors have, and they all go, what do? They talk about other people's research, right? And they usually talk about other people's research that happened in America or London or Harvard. Let's rip that up, shall we? And this is what I mean about being disruptive. Because a journal club is looking at, didn't they do brilliantly at doing that study, and does it make any difference here? So let's change that model. And maybe this is a sort of nice idea for all of you here who work in a clinical setting as well, or a lab setting. Start a research club. Don't call it a journal club, call it a research club. And we'll be really happy to help you do that. All you need is a couple of really keen beings to get it going. And then you just have a room, every Friday lunchtime, people come and they just brainstorm some really simple ideas. And I always say to people, if you can measure something to change something, what would it be? As simple as that. And I'm going to give you some examples of really straightforward studies that have happened through this way. And so having just a simple concept of just bring people together from a healthcare setting, whether they work in cardiology, maternal care, orthopedics, in a lab, pharmacies in the regions, just get them together, and then you can access all the tools to set that question and go through the steps, as I'll show you. But doing those really simple sessions, the other thing that we can do is offer things like supported classroom sessions. So you've got a group of people together, they're interested in doing research, they don't know where to start. Then there's a whole raft of online resources that they can access, but maybe it's nurses who never get time in front of a computer or don't have the first level of confidence to log on. You could just get them in front of some screens and somebody takes them through it, and then they're off. And then they run the research clubs themselves, and maybe they'll have more focus on nurses or community midwives or whoever it might be. So this blend of the online platform and literally championing it in person is where the magic happens. And I'm going to give you some examples. Next slide, please, where there's a slide manager. Super. So here we are with just the real beginnings of the MENA region, and this is where I really hope you all sign up and get involved. And wouldn't it be lovely if you start some research clubs, we can showcase those on here. So we really hope that we have some champions that come forward from across the MENA region and really begin to enable research to happen in settings and places where it wasn't happening before. And this is what we're going to also spend today and tomorrow in Cairo talking about. But do go on and have a look for the MENA region. Next slide, please. So if you dig into the global platform, this is what you'll find, that at the beginning it began as just a resource centre with access to things like, how do I set a research question? How do I develop a protocol? What does it mean to have a laboratory research lab? How do I do community engagement? Introduction to data science? All of those component cross-cutting topics was just really a sort of go-to place to find those generic tools. And then over the years, lots of organisations have, because this just worked from the outset, and the reason it worked is because whether you want to do a study in oncology, maternal care, Zika virus, malaria, HIV, TB, the basic elements of doing good research don't change, and that we've proven that over and over again. Of course, you need particular assays, you need your right outcome measures for your studies, you need study designs, but those basic blocks you need in the teams don't change. And so as soon as you start sharing across diseases like this, it's really incredible. It's so humbling how that's been sort of self-igniting. And so what's happened over the years is organisations have come along who want to work with would-be researchers. And so now, the people putting the knowledge into the Global Health Network are organisations like the WHO, like CEPI, the vaccine developers, like IDRC with this AI project. And so we've got over 60 different organisations who are sharing their knowledge on the Global Health Network. So now, those researchers working in their research clubs who want to find a template on how to design a new epidemiology study, or they want to develop a new lab assay, they can come and find resources that have been shared from these global organisations, also from across the global south, of course. And we have so many areas of translation, say between Brazil and the Lusophone-speaking countries, or everybody working on malaria across the global south. So what we've done is now begin to organise this, and I'm going to talk about the AI application, which is a real gap we have, because we've got 15 years worth of know-how now in this bucket of the Global Health Network knowledge, and we organise it into disease areas, to cross-cutting topics, and so the organisations that share their knowledge have their own area. So it's a little bit like Netflix or Spotify, that we try and organise it into genres, not quite as exciting as thrillers and comedy, but we organise around disease areas or topics. And then when the users come, hopefully they can find the information they need really easily. And then we try and curate this into some of these sort of resource hubs. So you might be looking at data science or community engagement, and you can hopefully, as fast as possible, find the information as quickly as you can. Next slide, please. So, these are some examples of the science park analogy here. So, if you're a member of the Global Health Network, you have automatic access to this incredible wealth of knowledge now. So, organisations like CEPI have their resources and technology here. So this is obviously around vaccines in particular, but they use this to really make sure that anybody wanting to do vaccine trials can find the tools and resources to be able to run really good vaccine trials, whoever they're working with, but also they want to be able to find new places to do vaccine clinical trials around the world. So it's like a dating site, really, in that sense, that it's these major organisations sharing their knowledge because they want to share their knowledge, but also it's a way for them to engage with frontline health workers and workforce and find it. And I've highlighted the AI for Health area in here because that gives you access to all the projects you're going to hear about through this project. The epidemic ethics area is run by WHO, for example, and that's a whole resource area to support people working in outbreaks and epidemics in general, and making sure that there's really high ethical standards. And so that's just as an example of the diversity of information on the platform. Next slide, please. So this is what people really come to the platform to find. And if you do get a research club going in your institution, and then you go into the resources and the training area of the Global Health Network, this is what you can find. So there's this mixture of pointing towards really excellent online training courses there. And these are translated into English, Spanish, French, Portuguese. We've got some in Mandarin, we've got some in Russian, we've got lots in Arabic. We'd like some more. Any volunteers? Wonderful. And it's, as I say, it's all about equity and access. And so the training courses are probably the sort of flagship that everybody comes to. They can do their GCP course, they can access how to set up a laboratory, all of these amazing things. But also the toolkits to do some of these in-person activities, how to set up a research club, doing a topic clinic. Maybe you want to run a session on how to do community engagement in research, or how do I approach data management. You can do a specialised topic clinic on any one session. And then a lot of what we do as well is try and measure this over time, so to try and really capture how people have taken these on board and are strengthening the research systems in their health research ecosystem. Next slide, please. So you can dig around and find all of these on the platform. So just a couple of examples how this has really delivered impact over the last few years. So this absolutely works every day, really trying to tackle the diseases of poverty or neglected diseases. The big infections, of course, HIV, TB, malaria, but things like leishmaniasis. We responded to the plague outbreak in Madagascar a few years ago, and also the non-communicable, really big disease burdens, maternal health, malnutrition. We talked yesterday, we had a meeting about doing some cancer studies. You know, research in cancer is a hugely neglected area in many low-resource settings, and access to pathways are really important areas need to be tackled. But if you just think about the disease outbreaks, we were really active in Zika, as I said, and in the dreadful Ebola outbreak a few years ago. And then COVID comes along. Where did all the funding go? The global north. Where do we need research? Everywhere. Everywhere. And the first thing we did was put an area up on the platform, which we used that diagram, because the other thing that happened is a ton of funding went into clinical trials. And we did a study at one point, and there was, on the clinical trials registry, there was 530 trials happening in the global north, all asking about the effectiveness of antivirals in COVID. Most of these were hospital-based studies, so day 10 to 14 of infection on antivirals. Now, any of us in the room who work in infectious diseases and virology, you don't treat viruses on day 14 of infection, you treat them on day 0, 1, 2, 3. These studies should have been in primary care to evaluate the potential antiviral effectiveness. They definitely should not have been in the hospital. Why were they in the hospital? Top of that pyramid. Who could get access to the funding straight away? The big guns that are always doing the same old, same old. And governments just threw money at them. Quick, do these trials. And they broke all the classic rules. It was the wrong question, the wrong population, and the wrong design. And they answered, what did we learn? Nothing. How much was, billions was wasted. Literally billions. And the WHO put out a blueprint for the research priorities in COVID, and it was all around vaccine and therapeutics. They asked the Global Health Network, they asked us to ask the world, what do they agree with the blueprint? Because they did it very quickly in Geneva, and it was a very small focus group. And so we ran the survey through the Global Health Network community to say, do you agree with the blueprint? And of course, we got a totally different response. What did the world really want to know? What's the perceptions about COVID and its transmission? Is there evidence on lockdowns and some of the public health interventions? And it was the beginning of vaccines coming through. We need to understand about vaccine hesitancy and the real uptake and the use of vaccines, and is it going to get to us? And the big one, diagnostics, of course. So it was, just a really great opportunity to show that for every single disease, we don't just need clinical trials, of course. And what I always say, and there's a few of us in the room at the WHO trials meeting recently, clinical trials don't happen in a vacuum. You cannot run a clinical trial by itself. And even if you have a good intervention to test, you need to have everything that's in that cycle. You need to have epidemiology, obviously, to understand the burden. You need genomics, maybe. You need to do health economics. You absolutely need to do social science to gain a good understanding of knowledge, attitudes, and practices, everything from treatment-seeking behaviour to perceptions about transmission. So what the Global Health Network is all about is trying to support every step of that ecosystem, every type of research, that every disease needs to happen. Again, Zika is a great example. There were no trials in Zika because there were no interventions. And what began as a vaccine program for looking at a vector-borne disease, once the good observational epidemiology happened, it was clear that it was also a sexually transmitted disease. And so and we were looking at pregnancy and the burden in pregnancy, but then suddenly the population shifted on if you were going to have a vaccine, who would you vaccinate? And so what the Global Health Network is absolutely all about, again, this sort of parity and equity, is trying to focus on all forms of health research and all the stages of each research study and everybody that needs to be involved in those research studies. Social scientists, epidemiologists, mathematicians and data scientists. I'm calling out to my friend at the front here. We need everybody, and everybody needs the skills. And so, whilst this has really shown how incredibly transformational this is as an outbreak, and all of these responses that the Global Health Network has worked on, this needs to happen every single day with all the diseases that we deal with every day, be they the long-standing burdens to health like TB and malaria, but also the sort of, applying this to every, oncology to pediatric diseases, everything. And so it happens over literally centuries for the diseases we've dealt with for as long as humanity, but we need to do all these studies all at once in a new outbreak. Next slide, please. So just one example of how this has come into play. About 18 months ago, we were working in Rwanda on a completely different program, doing some training about linking up genomics with epidemiology and how important it is not to do genomics in isolation, not to do epi in isolation, but if you're going to do genomics, what does your findings mean and how would you take that up to educate your population and public health messaging? And whilst we're there, some of the colleagues attending this course were from the far corner of DRC, an area called South Kivu, and they said, we're seeing this, we're seeing mpox, which is called monkeypox, and this was a disease that was transmitted between animals, but this is completely different. It's being sexually transmitted, and it's being transmitted in pregnancy, and also child to child. And it's devastating. And so, because they were part of these communities of practice and part of the Global Health Network and the local research networks, it was possible to mobilise a response. Now, this team in South Kivu had done no research before, completely research naive, and then by being able to connect them up and give them the support they needed, get the protocols in, help them do the studies, they're now leading their own studies. This absolutely was not about helicoptering people in to do studies that are going to happen in Oxford or Harvard. There's now a really strong, competent team in Bukavu who are able to run really high-quality international studies. And this is what needs to happen. And all of these things that they needed to do, that down the right-hand side, you could just take that list and then put it onto any disease you like, but these are the cross-cutting pieces that you need to give people competency to do straight away. So that's what this is all about. Next slide, please. A really nice example of what I was talking about earlier around workshopping within a healthcare setting. So in Nigeria, the Global Health Network Nigeria went into a hospital in the top north of the country, and they said to the team there, okay, and these, again, no research before, they just did a workshop and said, okay, what data have you got, or what questions would you like to ask that nobody's got any evidence on that could change something? And it turned out that the one they wanted to do was snake bite. And there was a ward in this hospital that has been running for 20 years, and I'm sure if any of the clinicians in the room are working, this is the story everywhere, right? They've been collecting data, their ward data, and this could be on paper. It doesn't need to be a funky electronic record system, but this is, I've seen this, Bangladesh, Pakistan, Nepal, it's always, the clinical staff will say to you, we collect this data, nobody analyses it. I'd like to analyse it, I don't know how. Everywhere. And so with these guys, we said, right, this is, what do you want to know? Well, we want to know which patients that come in with snakebite, who has the worst outcomes, and then what can we do to have a better outcome for those cases. And so they developed this nice data extraction form, set up a nice data system, they hold the data locally, they ran this analysis, and it turns out it was young men being bitten on the forearm. I'm a mother of 2 young men. This is what I call this muppetry in my house. This is young men, right? So they get bitten by a snake. What do? Nothing. They don't go for treatment, okay? And also, they didn't photograph the snake and they weren't wearing gloves and all of these things. So these young men would either have their limbs amputated or they'd die because they just thought they were too cool for school and didn't go and get treatment, or I got bitten by a snake. And they didn't bother taking a photograph of the snake. So now they've run this huge public health campaign in this area of Nigeria to say, wear gloves, by the way, young farmers, yeah, in the fields. And if you get bitten by a snake, go really quickly or you're going to lose an arm, and then that's really not cool. Or you might die, which is definitely not cool. And then also, you've all got your iPhones. Photograph the snake if you can, or at least remember what it looked like, because they didn't know what snake it was by the time they went in. So really nice public health education campaigns, and it's saving lives already. So this is the power of analysing data that already exists. And you can do this in any healthcare setting, and it doesn't need a big grant and people to come in from Europe or elsewhere. And this is what the research clubs can do. You know, what data do you hold now you can analyse and ask new questions of? Next slide, please. So this is the how you can do these research clubs and workshops. You know, just get people chatting and think about ideas, and then they can access all the tools and resources to do it. And it's so empowering for your teams as well, because this could work on literally every level of staff that you have, from community health workers right through. Next slide, please. So just a quick sort of jump to a slightly, I mentioned this earlier, but I honestly believe this is completely transformative. So there's a huge push now to, for every, I've got my MRO colleagues in the room, and there were some of us that were at the WHO meeting around this. There's a WHO action plan for clinical trials, and that follows the World Health Authority directive on trials. And even though it's wrapped up around trials, the whole spirit of this, if you read it, is around the health research ecosystem. And so the science division at WHO are really trying to push out supporting the health research ecosystem. And so it's exactly what we said earlier, that point about AI. This is literally transformational and can enable research to happen everywhere. But if it only happens in the global north, we have all failed. And it's the same as the story of AI, right? These are completely transformational opportunities to have health research embedded everywhere, but it has to be taken up everywhere. And this is back to my point earlier around we've got to work with our heads of our institutions, healthcare settings, policymakers right up to government to say, if you do research, there is a return on investment. I mean, look at the lives saved from those young men from snake bites. If you use antibiotics differently in pregnant mothers, there's endless examples. You can make immediate life-saving changes, and of course there's an economic return on investment. We had the meeting open talking about economic return on investments. That's what we have to argue with our politicians. So this really is a great, it looks very boring and very sort of WHO report, but it is literally transformational. And so what we're doing at the Global Health Network with the WHO Collaborating Centre to try and help implement this across the global south, but we have to do that together. And so we're going to be doing lots over the next few months and years about how people can take up these opportunities. Next slide, please. So this is often the sort of, it has everybody asleep, but if you do health research, there's a course called Good Clinical Practice that everybody needs to do. That's the main course that everybody takes on the Global Health Network. And so that's being updated to bring in some of these changes. And the really important parts of this that are so different, and this is what I mean about the opportunity that we mustn't lose, analysing real-world data. So that was what I just talked about with the snakebite example. Using data science transformatively, and there's so many really exciting opportunities I'm going to come back to at the end that we have to bring down to be applied everywhere. And the other really key area is patient-centric design and community engagement. We totally failed on that with COVID. You know, that's why that snakebite study was so good, because it talked about these labs from the beginning, you know, how we stop these boys, you know, getting bitten in the first place. You talk to them and you ask them why they behave like they do, and you design studies, patient-centric design. These are really important components that we can bring in, not just with one dull online course, but doing the courses, but doing tools to deliver them to your nurses in the workplace, having examples on how to take this up into policy and practice. Next slide, please. Just a little bit about the evolution of the Global Health Network. So this began in Oxford, as I say, nearly 15 years ago now, and it's just so humbling that it's this huge community now, and it's delivered with implementation partners and across the regions, as you can see, and men are proudly in the line up there. in everything I'm talking about around equity and hierarchies and fairness, it doesn't really work being University of Oxford led at all. And so what we've just moving to do is to take the Global Health Network into the UN and have a UN entity alongside organisations like Stop TB and Roll Back Malaria. There's an area within the UN that hosts these sorts of provisions of resources. And so we're just looking now to make that transition into the UN, and we hope that really makes it easier for groups to the whole point really is to take the Global Health Network into your institutions and to use this. So next slide, please. So just to finish off, these are the really simple steps and pathways. So I didn't really translate all the slides very well here. But you can find these steps, and this is exactly what we took the snakebite team through and the team with MPOX. Breaking it all down so research isn't scary and too off-putting, just so that you can take your team through these simple steps and run really good studies. Next slide. So this is what we're here to do today, is to talk about how can we harness AI into really helping with some of these transformative opportunities we have in health sciences, and really taking that technology out of the top of the pyramid and putting it in everybody's hands. And so that could be use of AI in diagnostics, in discovery pathways, in identifying new drugs and therapeutics, but we can also use it in really transforming access to knowledge and enabling research in every setting. So I really bucket up talking about good data science and taking data science technology and things like federated analysis and taking, keeping data in situ, right through to how do we use AI to make better treatment pathways or access to care or even discovering good information. So I'm really excited about what the rest of the day holds for us, and I'm really happy to take any questions. Next slide, please, and then that's the last one. So that's, next one. I just crept in. So this is, you are all, I hope, part of the Global Health Network family, and looking forward to working with you all. Thank you. Time for questions? Yeah, any questions?
حضرتك صح؟ Yes, we can. لا من ناحية بخليه.
اقدر امسكها وخلاص اسهل؟
لا
Please introduce yourselves, because it's nice to hear everybody here where you're from and where you work.
Hello, thank you very much for the talk. I'm Dr. Shem Gofford. I currently work with the...
Can't hear you, sorry.
Thank you very much. So I'm Dr. Shem Gofford. I currently work with the World Bank in DC on climate and health. We have a focus on AI, and I'm part of the Global Health Digital Innovation Foundation. My interest is asking, you were mentioning sort of the...
I'm really sorry, I can't hear you. The mic's not working, but it's...
Okay, so I guess I'll just have to yell a bit. Hopefully you can hear me. So I was going to ask about, when you were talking about the big players coming in and sort of leading. There's a big conversation around AI. Around AI causing convergence in approaches rather than actually innovating. So we've seen this with the MIT and Stanford studies around, this is mainly literature, but applies to social determinants of health. And likewise with the work of the Knowledge Lab, where we're less likely to get breakthroughs the more we involve AI, it seems, with the hesitancy of researchers to take risk. So I'm wondering, how likely is it to exacerbate research, not just with the big players, but to produce uniformity, versus how can we actually implement it to be innovative? Thank you very much.
No, brilliant. I think you've pretty much set the discussion for the day, because that's exactly the point. How do we make sure that AI is brought out of those sort of top-level siloed institutions and really applications that could be taken up everywhere? I think that's really what you're saying, and I think that's definitely not for me to answer, and I agree that needs to be what happens. I think that's really the discussion today on and applying, how do we apply it in research to make research shared. So yeah, great. And maybe we can hear from you later any ideas that you have to have that happen. Any other questions? Yes? I think we need the mic because I think everybody can hear, so they don't seem to be working.
I am Imam Badr. Thank you, Dr. Trudy. I'm associate professor here at Zurich City. Thank you for the amazing presentation. We can see a lot of potential from these slides. I love the snake bite example. So I have two questions. How to be really involved like a champion in the Global Health Network, and maybe there are what types of support that you can provide for if we want to start from data collection until building our own models and going for a translational project, for example. Are there any funding opportunities that we don't know about? So these are my two questions. Thank you so much.
Yeah, thank you. It's a perfect question. So it's in how do you get started on getting teams to work and set the questions and through the pathways. One of the things we're really going to be thinking about in the next few days is really increasing bringing the global health network to Egypt would be wonderful, and having an Egypt area stronger, and that this is, if you get together as groups as well and really share that because that expertise exists locally, but you can find it on the global health network and connect up. That slide I showed with all of those steps. So all of those opportunities to how to do each of those steps, like the snakebite teams did, is it's all there so you can be guided along. There's also signposts where you can find funding, but the funding question is a really good one, and this is part of that second point on that graph. Most research doesn't need to cost money. It needs time, and it needs support, and it might need some sort of, maybe putting in ethics applications or just some small resources maybe for whatever components you need, which should come from that's the point on return of investment. Especially these big practical studies. The snakebite study didn't cost anything. It just needed the time from the teams there and the support from their institution. And so that's one of the shifts we need to make, that you need to wait for a big grant from Wellcome or NIH or PATH or those, USAID. We've got to make research part of the pulse of health delivery, and that it's supported and funded within local health systems. And then you can do those pragmatic studies like the snakebite ones, but then you could go, then that grows your expertise, and then, of course, applying for grants and growing the research system is there, and there's a lot of signposts to where there's grants available, and also how to write a grant application are all also within the Global Health Network. And again, regionally, that's a really good thing to think about collectively, about working in collaborations to put grant applications in. So, thank you.
Can we interrupt the question after the break? We have been kind of right.
Sorry. Okay.
Thank you, Professor Trudy, for a powerful overview of research equity in global health. And now we have a presentation about transforming health systems in EMR, leveraging AI to advance universal health coverage by Dr. Awad Motoria. Dr. Awad Motoria is Director of the Universal Health Coverage Systems and WHO, EMRO. Dr. Motoria has more than 20 years of experience in health systems, health economics, and health finance. Dr. Awad, welcome.
Thank you very much for the introduction. Do I look nicer with this pen? Wonderful. So really, it's a great pleasure to be with you all. I really would like to thank all colleagues who are behind organizing this day. And it was really thrilling for me to be at Zuhair University. So this is the first time that I'm in this part of Cairo. I've been living in Egypt for the last 15 years, but it's my bad that I didn't come to this nice part of the city until now. Again, my name is Awad Mufariya. I'm Palestinian. I come from Palestine. And I've been working with WHO for the last 15 years. I'm Director of Universal Health Coverage and Health Systems. So I've been asked to share with you some reflections on how we can leverage AI tools and AI technology in order to enhance our work on health systems. So I'm not an AI expert, I'm not an IT expert, and I'm not even an health information system expert. But my expertise is in health economics, in health system development, and health system transformation. And this is what I'm leading with. So I try to raise more questions on what are the issues that we could identify, could be further helped if using different tools related to AI and the different development in technologies. So in my speech, I will be talking about health system transformation in the region. What is our regional agenda from WHO's side? I try to stick to the time of 20 minutes allocated to me, and then I will raise the questions related to AI. Let me start if this works. Was working? Yeah. Let me start by sharing with you why we need to think about a transforming health system, why we need to think about changing our approach towards health system development and health system implementation in countries, and regardless of the level of development, regardless of the level of income. And I mentioned that I work for the Eastern Mediterranean region, so just to share with you what we mean by the Eastern Mediterranean region. You have already heard the term MENA, Middle East and North Africa, which might have different definition and different boundaries. So I'll share with you what we mean by the Eastern Mediterranean region. And given that I want to focus primarily on universal health coverage, which is a very important goal for health system work, I'll share with you where we stand in the region with regard to universal health coverage. And then I'll share the regional agenda for health system development. And I will conclude with some key questions, 4 questions related where I would propose for AI interventions to be of help for our work on health system. So, first of all, why do we need to think differently about health systems? I think health system as a concept is not an old and something new one. We have been talking about health system for the last 3 decades or so. But what we have been observing lately is that many of the frameworks, many of the approaches for health system development have failed. And that failure has been very strongly highlighted during the pandemic. So many of the countries which we were looking after as the model countries for their health system development, and we were trying to replicate basically what they were doing in their health system, were amongst those who were hit the most by the pandemic. So for us, it is because the status quo is not working, and because the responsibility on us as the people who are working on health system, on public health, is really, really huge. There is this short editorial that came out in The Lancet in October 2021, almost a year after the start of the pandemic. It is one of the offlines that Dr. Richard Horton writes regularly in his journal, the journal that he edits in The Lancet, where he says that if you want to identify a crisis of a similar magnitude of COVID, one has to go back to the Second World War. And he says that what happens in the world is not of less magnitude than what happened in the Second World War. However, what has happened at the Second World War, that many thinkers have emerged, a lot of things have developed in the global political agenda, but also global health agenda. The UN was established, WHO was established, and there were many people, NHS in the UK was established. And then with people thinking how we should address these health issues. Yet, for our generation, we do not see that is happening. We do not see people who have emerged to rethink what the basis of what we are doing in public health, in health systems. And that's why he, in this short editorial, it is 1 page, I recommend for all of you to pay attention to, especially for the emerging researchers. He refers to our generation, I'm considering myself young to be part of this generation, as the generation of ghosts. And personally, I have taken it very seriously, and I'm sure many people have taken that very seriously. And it pushes us to think and to rethink differently what has happened wrong in order to rethink our health systems moving forward. So coming now to the topic of health systems, I mentioned that for the last almost 4 decades, we have been talking about health system. In WHO, we have a landmark report that was published in the year 2000, which has provided the first complete definition of what a health system is about. Oftentimes, we confuse health systems with service delivery. We're delivering services to individuals. Sometimes we take it at the population level, but we think about the provision of services and oftentimes curative care for people. However, in this report, it's one of the annual reports of WHO. We refer to it as the World Health Report. We define health systems as all institutions and all activities that have as a primary intent, as a main focus, either to maintain the level of health of the population, or to improve it, or to restore it, to bring it back to where it was after a certain health condition. This means that health system is bigger than a Ministry of Health. This means that health system is bigger than the health sector, taking into account all the institutions within the health sector. However, it's not everything at the same time. If we eat better, that contributes to improving our health. If we exercise, that contributes to improving our health. But nutrition is not part of the health system. It has its own nutrition system. Exercising is not part of the health system because the primary intent is not health. When the primary intent is either to maintain, to restore, or to improve, then it becomes part of the health system. This is a complex construct. And as for any complex construct, to understand it, one has to decompose it, deconstruct it into its components. And that was what we have done in the year 2007, 7 years later. We came up with this framework that people started referring to as the building blocks framework, where this notion of health system has been dissected into 6 components. We started talking about governance and leadership, financing, health workforce, service delivery, information, technologies, as 6 components of any health system in the world that need to work together to fulfill the goals of a health system, which are 3. They were defined as 3 in that report. Improving health, responding to what we call the non-medical needs of the population, and ensuring financial protection. Because we don't want people to fall into poverty or to face financial hardship when they go and demand health services. This framework has been used by many countries to analyze their health system and to identify where are the challenges, where are the gaps. It has been less helpful, although it has been used as such by many countries, has been less helpful to formulate a vision and a strategy for developing and strengthening health systems. This is because you cannot think of a health workforce agenda in isolation of your service delivery model or in isolation of your health financing arrangement. That's why a few years later, in 2010, WHO came with this concept. It's again, the concept that existed, but we framed it in a more concrete manner, the concept of universal health coverage, which became the ultimate goal of any health system. We want these 6 building blocks to work together to fulfill the goal of universal health coverage. What do we mean by universal health coverage? It means that everyone in a society has access to her or his needed services in good quality and with financial protection. This is why now many countries, Egypt, you enacted a law in 2018 on universal health insurance that started thinking how we can shape our health system to advance universal health coverage. But universal health coverage continues to be associated with the services, individual and population services. While we know that health is bigger than service provision, bigger, as I mentioned initially, of the health sector and of the health system. That's why in 2018, 8 years later, which coincided with what we call the Al-Ma'ata Declaration 1978, when the notion of primary health care came about. So 40 years later, there was a new declaration on primary health care that tried to take us outside universal health coverage and outside the health system and outside the classical definition of primary health care. And we started talking about 3 components of primary health care. So when we think about developing a primary health care system or reorienting our health system on the foundation of primary health care, we now think about the first component, which is the first level of care. We refer to it as primary care, but also essential public health functions. These are population-based interventions. We refer to multi-sectorality, the role of other sectors in improving and maintaining and promoting health. And we refer to the role of communities, the community engagement and individual engagement. So this is how we have been evolving. I gave you the definition of a health system. We dissected it into its components. We went into universal health coverage, and I'm bringing in the notion of primary health care as the foundation for reorienting our health system to advance the health and well-being of individuals. This was 2018. 2020, we had COVID. COVID, again, as I mentioned, shaped our thinking and our realization of what is happening in the health system. And with COVID, we started realizing the importance of bringing the health security agenda along with the universal health coverage agenda. And the requirements of each of these two goals are completely different. So if you want to have a health system that guarantees health security, you need the health system to be resilient. If you want to have a health system that guarantees the goal of universal health coverage, you want it to be equitable. You want to be equitable, efficient. So if you want to build a health system that advances these two goals, you need a different foundation other than the 6 building blocks or only universal health coverage or only primary health care. This is the definition of universal health coverage. I already shared it with you, just for you to keep. I'm leaving my slides with you as well. When we talk about health security, it means being able to predict a risk, detecting, responding to it, and emerging from it stronger than before by learning from the mistakes that we are facing with that risk. Let me now come to our region and how this is translated in our book. So I refer to the Eastern Mediterranean region. This is our map. It extends from Morocco in the west to Pakistan in the east. We have around 800, almost 700 million people living in the 22. There are 21 countries and the occupied Palestinian territory, which is unfortunately until now not a full recognized member state of the organization, not a country yet. But these are the 22 countries and territories with whom we work. They are very diverse. We have high-income countries. These are the Gulf Cooperation Council countries, six of our countries in the region. We have low-income countries. Now they are 5. There used to be 6. One of them has upgraded itself to a lower middle-income country. And the remaining ones, the 12, are divided between lower middle and upper middle-income countries. So they are very diverse. So if you want to talk to our region, I cannot go and advise Qatar the same way I would advise Yemen or Somalia, with all due respect, because the needs are different. The context is completely different. So we have to tailor this to the context of the countries. But maybe the main feature that is characterizing our region is the large number of conflicts, political instabilities, and also other types of crises, natural-related floods, earthquakes, droughts in some countries. We estimate in our region that there are around 110 million, almost 1 in every 7 individuals in the region who are in need for humanitarian assistance. As I speak, we have almost 16 graded emergencies in the region, some of which are the highest grade in terms of our classification of emergencies. We have last year we had 75 outbreaks in the region. People know about COVID, but there are many outbreaks that are happening in the region. And unfortunately, in the recent conflicts, whether in Syria, in Sudan, in Palestine, what is happening in Gaza, we are observing a lot of attacks on healthcare and health workers and health facilities. This is a new feature of the conflict, unfortunately, that is happening nowadays. These are just some pictures from some of the crises that are ongoing in the region. In Gaza, in Lebanon, Dr. Shadi Saleh has spoken, Sudan, but also Syria, and hopefully Syria will be emerging now from the over 15 years of instability in the country towards a rebuilding. I was in Syria last month in order to start thinking of the health system recovery and the health system rebuilding. Coming now to universal health coverage, you remember the definition. There will be a quiz at the end of the session, so please pay good attention. It's about access, about the quality, and it's about financial protection. In WHO and in EU and at large, as part of the Sustainable Development Agenda, we have 2 indicators to measure universal health coverage. We look at the access to services, and we look at the financial protection. And financial protection, we measure it by its opposite, which is the financial hardship. So we look at how many people access their needed services and how many people face difficulty, financial difficulty, when they access their needed health services. For that first one, the service coverage, if you study public health, you would have come across the 3.8.1. This is the indicator related to service coverage. 3.8.2 is related to measuring the financial hardship. So where we stand with regard to this? WHO and World Bank, every 2 years, we publish a report to monitor where the world and every country stands with regard to universal health coverage. The last report was published on the 23rd of September, 2023. You know why 23rd of September? It's my birthday, which is not. but that was the occasion of the second high-level meeting on universal health coverage that took place at the UN General Assembly in New York. So we published this report to show where the world wished to show our heads of states what is happening with the commitment that they have made in 2015 to achieve by 2000. And what that report showed, so the resolution, I mean, the color is not clear on my screen, it's different. The report found that 4.5 billion, almost 57% of the world population do not have access to their needed services. And more than 2 billion of those who access face financial hardship, 26% of the world population. Now this is globally. What is happening in our region is even more dire. In our region, the service coverage has been improving, but slower than what is happening in other regions. And with regard to financial hardship, the situation has been deteriorating. It has been worsening over the last 20 years. More and more people are facing financial hardship because when they go and demand their health care services. And if you pick some of the countries that what we refer to as FCS or FCB, these are the fragile, conflict-affected, and vulnerable settings, like Afghanistan, Pakistan, which has its own emergency, but Sudan, Syria, for whom we have some data, you would find the situation is even more and more challenging. We have done some simulation and projections and estimation for our region in particular. So I gave you the figures globally. 57%, 4.5 billion people do not access, around 2 billion have financial hardship. Our region, we estimate that 2/3 of the 700 million people in the region do not have access to their needed services, 2/3, and around 100 million face financial hardship. And we can see how the financial hardship has been increasing over time. Just to compare our region to the world, so the service coverage, we measure it using an index. It's a composite index of 14 tracer indicators. It's like a thermometer. It's not a percentage here. Our average is 57. The global average is 68. So we are 11 points less than the global average. And the financial hardship, one in every 8 individual in our region face financial hardship. Now, what we are doing as WHO to change this, to build systems that are equitable and that are resilient to advance the dual goals of universal health coverage and health security. We have worked with our member states, with our countries, to rethink our future health systems, to move them from health systems that are focused on curative care to health systems that promote health and well-being. We want them to be health systems that integrate equity along with efficiency. We want them to be health systems that do not only think about their national boundaries. I mean, while we were talking about COVID in Egypt, COVID in Jordan, COVID in Palestine, the virus was spreading from one country to the other within days, if not within hours. So how to bring a global health agenda within our national health agenda? And how to bring in the social determinants of health, the intersectorality into our health system. So we came up with this implementation framework for helping countries developing visions and strategies to advance their health system. So we say that any health system should have two goals: universal health coverage and health security. If you want to advance universal health coverage, you need to reorient your health system based on the foundation of the primary health care approach, the three components: primary care and essential public health functions, multisectorality, and community engagement. To get the health security agenda, we need to bring health emergency and disaster risk management within our thinking of health system. And this is what we do in all countries now. So we help countries think about developing these visions and the strategies to advance these dual goals. We believe if we do so, we will fulfill the goal of number 3 on health and well-being, but we will also contribute to social and economic development in countries. We have identified 7 regional priorities that we are working on. The first one, which we refer to as the step 0. If you do nothing, think about the first one, which is investing in health emergency and disaster risk management, ensuring that emergency is taken care of. Then the second priority is building the institution, starting by ministries of health. Ministries of health of the 21st century, ministries of health of post-COVID should not be the same as ministries of health before. So to build and optimize and to reorient ministries of health for the future. The third one is to reshape the models of care. How services are organized, how services are managed, how benefits are selected and delivered. The fourth regional priority, which became one of our regional director flagship initiatives, is to invest in the health workforce. We want to invest more. We want to invest better by focusing on the primary care workforce. We want to invest for the future by changing health professional education program. And we want to invest together by bringing in collaboration between countries to benefit from diaspora and different, to benefit their own countries of origin or other. The fifth region priority is the financial protection. We want to change this picture of 1 in every 8 individuals facing financial hardship. The sixth one, which is the second flagship initiative of our regional director, is to improve access to medicines, vaccines, medical products, and others. We work a lot on building regulatory capacities in countries. We are establishing a pooled procurement arrangement for selected commodities. We are working on enhancing local production to contribute to better health security, but also to better universal health coverage. And the last priority is emphasizing that we need to do all of this in harmony and in coordination, not in a siloed way, not one by one, but all of them should be tackled together. Now, having shared with you our vision and our strategy for working with countries, now I was thinking about what I could bring to the forum, like one that is focused on AI and how AI can help us with this agenda. So I could think of 4 key areas where AI can be of help for advancing this agenda. The first one is related to integrating service delivery. So to look at how we can shape the model of care, how we can leverage, for instance, telehealth in the provision of services to ensure that services are integrated, to ensure that our system is built on and centered around individuals, around not only patients, but individuals and societies, and not around diseases and institutions. So this is something that AI can help us with big time, and you know, precision medicine is something that is booming. We are not leveraging it much, so to make use of that. The second area is to make sure that people-centeredness, as I mentioned, and to ensure that this important agenda of aging that is becoming a very acute public health challenge, to how we can leverage AI for ensuring long-term care for people with non-communicable diseases and people suffering. We were just discussing the question of palliative care and so on and so forth. The third area is related, for me, the way I thought about it is in association with digitalization. So how we can use digital platform to generate timely and precise and relevant information and data to inform decision making, but also to tailor the services provided to the needs of every individual, whether in emergency setting or in normal setting, but also to inform the decision making process. And last but not least, to come back to the health system building blocks and the health system inputs. So how we can use AI to improve the supply chain, the way that medicines and vaccines flow within the health system. How to use it to build the capacities of health workforce by tailoring the training to their needs and to the work that they are expected to do. And last but not least, how to use AI for better financial management. You know, we have a lot, I could say a lot, I'm a health economist by trade. My PhD is in health economics, so I can speak a lot to this point in particular, but maybe in the discussion. So how we can use AI-generated data to tailor the payment methods for providers, to get information about the cost of services that are being provided. So a lot can be said. I know it is a booming and it's evolving discipline, and I very much hope that we will have further interaction and collaboration to leverage the AI instruments or to enhance the transformation agenda in health system. Thank you very much. Just remind you, USC Health Security and the Private Health. You want this? No.
Nice. Thank you, Dr. Ahmad. Thank you for outlining the opportunities to drive the system-level impact with AI. We really appreciate your insights. I would really apologize for the taking a longer time than scheduled in the agenda, but we will have now Dr. Adash Rashdini from the WHO Europe, and after that we will have a break for 10 minutes for the coffee break. I would welcome to the stage Professor Adash Rashdini, who is the Director of Science, Information and Dissemination at the WHO in Rome. Since 2015, he has led the WHO regional agenda on this informed policymaking, health information systems, digital health,
research, promotion, and governance, and knowledge sharing. Dr. Arash will share with us presentations about science ecosystem, AI, and enhanced policy making for health, and this is from the WHO initiatives in the Euro region. Dr. Arash.
Many thanks indeed, Marina, and it's a pleasure to be here at the Soil City. Thanks, Dr. Mataria. I know definitely the audience wanted to ask questions, but I mean, for saving time, you sort of went beyond that. The three of us had 1 hour, and I think we are already beyond the full 1 hour. And so I try to be quick, so that not to take too much of your time, but at the same time, making sure that the key elements will be covered well. So what I'm going to talk about, there are first 4 elements into it. The first 2 elements I go quickly, so status of research in EMR countries. That's important to know, I mean, given that we are in the city of science and innovation. And then sort of a quick reference to the WHO strategy for digital health and for achieving OAC, which is the focus of the talk. I will spend more time in the last 2 points about the issue of the promises of AI and the challenges and the things that, I mean, the young population here should help to resolve. I mean, achieving some of those promises, but avoiding the challenges. Okay, obviously, I don't need to talk about the region again. So now, I think by now, even if you didn't know what the region is, I mean, that's the definition from Pakistan to Morocco and then south up to Somalia. So in terms of the regional strategy for digital health, I mean, the 4 key elements: digital health governance, the strategies, I mean, enabling the people-centered health system. So we don't see digital health as a technology, we see it as a tool, as part of the health system development, linked with the program. So that's the important thing in the perspective of WHO. Even when we have a sort of very technical documents on certain elements of the digital health, is actually with the concept of this should be a support. And that's the perspective that always matters. It's important, but then collaboration. Obviously, health sector is not the prime customer for digital, and we are not the prime producer. A big challenge is that also the ministries of health are also not very strong technically in these areas. Those of them they mean that we need to define the role really well, but it also shows the challenge. It's totally possible, and we see that in countries that, for example, the ministries who are not responsible for health become responsible for digital health in the country because they have the technical advantage. And then as a result of some of those innovations are not necessarily responding to objectives of health. So that's the thing that we focus a lot. And with that in mind, we have a very close collaboration with ITU in the region, which is really important as the key UN agency for information technology. So for a status of research in the region, this is a slide actually, the first time I used it was 8 years ago in Islamabad in front of the ministers of health of the region. That was when we were testing with the ministers whether there is interest in further work on evidence-informed policymaking in the region. We identified a few challenges, and some of these challenges still remain. I will show you in the next slide. I mean, this was based on the summary of 5 years of production of research in the region. We did it for 15 years, we are updating it now. There's still three universities in 22 countries of the region produce 10% of research publication from all 22 countries of the region. Overall, we are not producing enough, but that shows the mismatch. Many of the research may not be resulting in answering the policy questions, and many of the results, the research are not following all the standards. So when we talk of science ecosystem, we are actually considering all of those together, and those elements could go together. So in a way, the fact is this old, cartoon that probably many of you have seen. So you start from both different sides, you get together and then, oh, I need to do something now because they are not addressing each other. So this is a sort of, it's about 25 most prolific institutions in the region. So the 3 universities, you can, 2 universities from Iran, 1 from Saudi Arabia. Together they publish more than 10%. The 4th university is actually from Egypt, Cairo University. And among the sort of the 25 universities of the region, there are a few universities from Egypt, from your beloved country and the country that you are actually using as a home for WHO regional office. So within that, I mean, the capacity is demonstrated, and this is something we use it as a monitoring status, because that also helps us to focus our capacity building efforts in the region and in the countries. On clinical trials, I come to this a bit further. This is an important area that after COVID pandemic became a prime focus of the WHO. I mean, we monitored on the trials that were conducted on COVID during the COVID. So my team, one of their job was that to looking at every single study, every single report, every evening, at least for the first 6 months, but 2-3 times per week for the last another 12 months. For 18 months, we were monitoring to make sure the latest evidence is given to the decision maker at the earliest possible. But as part of that monitoring, we also observed there were many trials they didn't look correct. The topic was not relevant, the design was not correct, and in the end, most of the evidence that actually helped decision making globally on what to do and how to address came from 2-3 studies. That's it. I mean, so that shows that we need to do more. In our region, the trials are expanding further, but our share in global trials is also expanding further. So now it's closer to 8%, which is similar to the population share of the region. So then the focus is not about the numbers. It should be better quality, larger size, randomized controlled trials. Again, these are the programs we are now monitoring regularly. So you heard about the reference to WHO framework for this. I mean, this is the the benchmarking tools and the approaches. And then we also had a regional consultation. And within that, based on that, we are not only focusing on randomized controlled trials, also cohort studies. I referred to this in a meeting that we had in American University in Cairo recently on certain cohorts for aging population, again linked to that agenda. Okay, so plenty to discuss on those areas. I went through them pretty rapid. So getting to these areas of AI, without going to the technicality, I want to talk about promises, challenges, and what we are facing. I'm quoting Eric Topol. Many of you might have heard his name. If you have not heard his name, I would say remember his name. Follow his account on Twitter. One of the best science communicators. He's a scientist, but he's actually excellent in science communication. I'm quoting what he published as a short piece in the Lancet in 24. So you do a chest X-ray, imagine that, and then the chest X-ray, you do it, for example, for a screening for tuberculosis. And then it tells you what are your risk of coronary disease, what are the risk of your diabetes, perhaps you need to take this medicine, etc. The way AI being used, this is the promise we are looking for. So much more information from much more simpler set of data, but having good quality, obviously, and then having good system. I will come to that later. This is the image we are having, and this is the promise that every AI package that comes into play usually gives us. Reality of making that into action is far from reality of it. But at the same time, how to govern this, how to supervise this, how to make sure the side effects are not addressed, how to make sure, so imagine all of us doing so here, let's say a big population, doing this, and all of this is given to us. How are we going to receive the service with the same standard? If you are not doing the health system issues that Awad mentioned that earlier, so then knowing all of those doesn't make change in health outcome. So AI in health sector, several areas. I mean, service delivery quality, already referred to that. It's a big focus, and a lot is happening. I was presenting last year in one university in the region, and young colleagues were sitting there, and I explained some example, and then 2-3 examples, actually people raised hand. They said, we've done AI behind this imaging thing, we've done AI on that area, and to me the issue was none of them had gone through the regulatory phases, but being tested at the same time in hospitals for service delivery. Population identification and targeting. I mean, we heard a question about the population-related issue. Identifying where to target, where to take it forward. Data verification, fraud detection. A lot of this, I mean, machine learning. I remember 20 years ago, I supervised a PhD student. We used machine learning to identify fraud in prescriptions. So the language has changed. Today we call all of that AI, but some of these are not that new. They have a big history that all of that should be used. Evidence-informed decision making, I come to that in a second, in a few minutes basically. Research efficiency and sort of timeliness. In the same WHO initiative, one thing that we are doing is that for trial registration, many of you probably don't have health background, and some of you may not know what a randomized controlled trial is. It's the gold standard, just saying that you have a medicine, you don't know whether it works or not. You divide the population between two groups. Some people get the medicine, some people don't. And this is not making people guinea piggy. That's not it. It's actually ensuring that treatment is effective. It's the best moral, ethical way to test that. So, but because there is a system, a big system to supervise that, a lot of details should be provided. So, some of those provisions of data for governance purposes takes hours, days of the times of the team. So AI even is being used to do that for researchers so that they save time. A lot is done also in community-related research for data collection and survey. Now we are testing using AI for surveillance purposes, using the media reports to see whether there is a disease emerging in one neighborhood that you are not aware of, for example. Human resource capacity and management, a lot on that one, so it doesn't need explanation. Drug development, you probably heard about the Nobel laureate in 24. Two of them were related to use of AI for finding new medicine. And that would make it's making a massive change. So, however, when it comes to the sort of, I put a few studies here. These are clinical. The audience is not clinical here, but the focus of our work in WHO is clinical area. So as you can see, these are examples of how in certain settings AI proved to be really effective in identification, in better diagnosis, in finding the better way of managing the patient. This is one thing. If I search today, I did this search several months ago, I will find a few very beautiful, more examples tested in the studies, so that, you have evidence of effect as well. It's not just promise of a company or a health provider, it's actually research study. The main challenge is not this element. The main challenge is that if I go beyond this one, can I introduce this in the whole healthcare setting processes? That's the thing that we are focusing on. That's the thing that is the headache, the main issue. Recently, we had a meeting, sort of involving several institutions in Europe, and we were participating in that. Most of the work that is happening is that we do not know how to be quick enough to follow the AI inventions, to be able to check whether they are good enough, be quick enough to say whether it's working or not, while the AI hasn't changed, while we are doing all of those things. So that's the reality of how the system should work and respond to the process. Okay, now it's a test, a very small sort of demonstration of AI. I use it as a metaphor here. So this is a photo I took somewhere in Egypt, so probably some of you would recognize. What do you see in the photo? Maybe one or two people, just tell me what you see. You see a bird, please, the gentleman in the front row. So what do you see? Speak loudly, please. You see a bird, what else do you see? You see, yes, some leaves that could be from a tree, okay? So some of you might see more or might see less, so depending where you are. So if I make this photo a bit bigger, so I just enlarge the photo. So what do we see here? More than the bird and the leaves that we have here. Anything else? Say it again. Sorry, I can't hear you. More details. Tell me what details you see. Now I want to ask you about the details. Buildings, there are some buildings in the back. So if you don't know, you are Egyptian, and you don't know where this photo was taken, do you have any guess? Where could it be? So difficult, I know, unless you've done a similar photo from there yourself. Could be administrative capital, okay? So that's a guess here, a good guess. Nasser City, okay. Okay, but you realize, so the quality of the photo reduced. I tried to make it bigger with more details. But then this is the real photo that I took. What else do you see? There are some dots here. What is your guess of those dots? Anyone? I mean, there were insects flying around the sort of the, and you can see these are not trees, obviously, they are grass here. And then the building, you see the cranes in the back. So now you know that there are many insects, so the environment is wet. From the grass, you can guess probably which part. This is the marsh areas near Alex. That's the sort of the coastal area, and this is one. So you can guess the location, you can guess the sort of environment. That's what AI is all about. I mean, sort of details from it, and so you just. When I was taking the photo, I wasn't thinking about the insects. I was thinking about the bird. I was trying hard to make sure that while the beaks are open, I capture the photo. That was my focus. I go to it and I really. What I have is that sort of good technology, a good camera that gives me good quality photo. Probably good photographer behind, but I'm not going to say that. So the eye, so the details that I focus, but then also the knowledge about those things. So if you don't guess it as a bird, as a sort of insect, you wouldn't know more. So you need to know that. But most important is about the interpretation. And that's the bit I'm going to focus on it in another example. This is again, no, sorry. I'll come to that. Just hold on with me here because I don't want to go back and forth. In service delivery, many areas, diagnostic areas I mentioned. Again, the challenge I highlighted, so how we can address, so deep studies we do. So I want to be quick here. There are a lot of risks there. If identify the risk that do not exist, how do we change it? Sorry about that. I didn't realize. So in the health sector, let's say if I have a better eye to diagnose, that means I may diagnose the things that are wrong. So, I mean, we all know about breast screening, use of mammography. You know, there is an age. We say don't do a screening, not testing when someone has symptoms, but don't screen below a certain age. Why? Because you detect more false positives than real things. So you make anxiety, cause, even damage to people by diagnosing the thing. With AI, you can diagnose 100 times more if you you are not careful of the, sort of those side effects, etc. Okay, let's go back to my intervention story. I should have put this there. So this is a real scenario. It's my game with ChatGPT. I did this a few months ago, maybe 2-3 months ago. So using AI for decision making, and this is the one that I want to focus. The question I had was, so do you know what is shingles disease? Anyone knows here? So there are many non-clinicians. You know what is chickenpox? Yes, everybody knows chickenpox. So when we catch chickenpox, probably most of us, probably all of us have had it in the childhood. The virus usually do not disappear. It stays somewhere in your body. In some people, when they get older, it appears as a new disease. We call it shingle, which is really painful, really awful. If you've seen one patient with shingles, you never want it. It doesn't kill you, but it debilitates you for several days, even weeks. It's a really bad thing. So now there is a vaccine for it. So my question from ChatGPT was, so if I can read it, do I need a vaccine with a childhood history of chickenpox? So I asked ChatGPT. And the answer is yes. If you are over 50, which I am, so it's recommended that you take the vaccine. Okay, so far so good. Then my second question was that, well, if I take this vaccine, apart from preventing shingles, I mean, sort of that may occur later in my life, are there any other benefit I might get from this vaccine? Okay. And the ChatGPT response you can see, some of them are exact quotes from the response I received. So the summary that ChatGPT gives you in the end. So in a way, sort of using the, sorry, I can't read my notes here, apologies for that. Yeah, I mean, sort of focus on there was a detailed response telling me about the, oh no. Yeah, with my eyesight, then I would be in more difficulty. I would need the glasses for that. So I need a sort of an AI tool that works both for me here. So the point is that the response I remember. It says, It listed the benefits of not having the disease without referring to it. For example, you would have less pain, less anxiety, peace of mind, calmness, less cost, but no other benefits. So that was the result. I said, sort of, what about any other? So what you said, these are all benefits from not catching the disease. I was playing with ChatGPT. Tell me any other benefit that it can give you. Then it actually summarized, saying that, as I told you in a way, so very politely, as ChatGPT does, there is no further benefit beyond that. Do you want me to talk about side effects? Maybe you're worried. That was the reaction. Because I knew there are further benefits from elsewhere, that was why actually that was a good test. Then I told ChatGPT, what about the certain benefits from prevention of Alzheimer's disease and dementia? So there are new studies showing that this vaccine may actually help in preventing dementia, okay? Suddenly, ChatGPT became the knowledge house. Gave me a detailed list of how those benefits are coming, even listed the papers one by one, saying that do you need more information? I can get data. But imagine, I knew the answer. If I didn't know the answer, I would be happy up there. So this is the way, how I define AI most of the time works as a very rapid, knowledgeable expert, not necessarily what we call critical thinker that needs to weigh evidence one way or the other. That's the challenge. I'm turning the sort of AI from an expert. Being an expert is like, so you go to the best doctor in your town. You give them, her or his, a few signs, symptoms, they make diagnosis, they make sort of recommendation, they test you, they ask you what to do. Most of the time it's really good. It's really good. But why do you do critical appraisal studies? Why do you do national guidelines? Why do you spend so much time on evidence? Because the experts might be biased, may not be informed of the latest evidence, may not have seen it. ChatGPT is not, AI is not that they won't say they know it, but the way that they focus in part of information, but not on the other, these are the biases that we need to control. What we are doing now, so this is a case from DMJ for clinical decision making, and you can refer to this later on yourself, I'm not going to it. And this is an example for AI. So within our regional framework, after that 2017 presentation, we worked on a sort of regional framework, which was approved in 2019. It has been our sort of bread and butter for working with countries of the region in the last few years. Part of that, we are actually, in the last 18 months, we are working with a sort of AI approach to support decision making, and that resulted as part of the COVID response. So because, the experience we had, how to respond, we said, if AI is doing everything, so a minister is asking a question now, why can't we be able to answer validly, responsibly, in a short period of time? So we need AI to be able to do that. But as WHO, we never release things unless we are really, really sure. So we've been testing it. The challenge is that it helps us very quickly to identify, it helps us to extract data, it helps us even sometimes to synthesize. We have challenges in critical appraisal, we have challenges in interpreting the findings into decisions, and we haven't been able to solve that yet. And we are working with some big thinkers. Last week I was in South Africa in ESIC meeting. I know Mohammed was supposed to attend there, but he missed his flight. He told me this morning. And because of the the terrible situation we had last week, over the last 2 weeks in the region, on top of other terrible situations that we've had in the last several months in our region, in several countries, unfortunately. But anyhow, within that ESIC, that was a global consortium to focus on evidence synthesis, not just in health, in education, criminal justice, development, agriculture, all sectors were there. And very many innovations of AI was part of the discussion. A big group working on that. I was in the governance group, a technical group. It seems that solutions are not that visible and further work needs to be done, despite all the examples. So what we need is to move from AI as an expert to AI as a critical thinker. And that's the thing that is the focus of the work. And I guess, I stop here. Thank you.